Yes, so good evening, everyone. Let's start without wasting the time. Thank you very much. Good evening. I'm Dr. Munjal. I'm hemat-oncologist and medical oncologist as well, and a fellow in bone marrow transplant. So I'm practicing hematology oncology for almost close to 20 years now. Treated more than 100,000 patients so far for hemat-oncology, and I have a quite good experience in coaching as well. So hopefully I'll take you to the journey of very basics and very interesting questions I prepared for you guys with lots of concept clarity, and I would be glad and happy if you ask a lot of questions to me, right? So feel free to ask me any questions. Don't hesitate, right? Every question is a valid question. So don't think that this is a silly question. Nothing is silly. Absolutely everything is valid. So very quickly going through this is medical MCQ for all, providing all study material, coaching for all exams, including PROMETRIC 1000 MCQ book, ebook as well, online subscription, WhatsApp subscription, Oman viva coaching, and subscription data flow services, short package, mobile application, and dedicated mock test, and um, uh, still more. We are developing more things on this platform, so we'll announce very soon. As I introduce myself, we have lots of excellent coach in our team. Dr. Arti is a consultant pediatrician taking pediatric classes. Dr. Maddie is a very popular coach and a speaker as well. She is an internal medicine lady. Dr. Ankit is also a gastroenterologist. Dr. Shikha and Dr. Deepali both are consultant gynecologists, and there are a lot of IT support team. Dr. Anjali data flow team. This is our hard copy book, and we have lots of promotional discounted offers for coaching, so you can inquire later on. Data flow services, mock test, and there are a lot of things. The last but not the least, I strongly recommend those who are new, you must subscribe the Medical MCQ for All YouTube channel, because this channel contains absolutely very high yield questions with DHA, hard MOH. So this is on the same name. This is the same picture of mine, Medical MCQ for All. So tremendous videos are uploaded right here. So you can see one by one. And let me tell you, there is no repetition of the questions in every mock test. So somebody is thinking, sir, there are hundreds of mock tests. So you can start with the latest one, right? And there is no repetition, believe me. So you will enjoy each and every mock test. So try to cultivate habit. So let's start with the first questions with proper understanding. So let me, sorry, share this. This was done last time. So first questions in front of your screen. What is a single most accurate test for myeloma? Options are skull X-ray, bone marrow biopsy, 24-hour urine for protein, serum protein electrophoresis, urine immunoelectrophoresis.
One
So
second.
think over it.
Not
We need three. We need a three things. We need a diagnosis. We need to know the investigation, and we need to know the treatment as well. So this is my standard triad, right? For every I mean lecture I give used to give this triad, right?
अच्छा
So you must
चलो
give little time, and you can answer this. You can post your answer in the chat box, right? So they had given the diagnosis already, right? Either they ask you in the exam either diagnosis or investigation or treatment. So what you need to do from today onwards, in every MCQ multiple choice questions, you need to ask three questions to yourself. So if you are solving 50 MCQ a day, means you are solving 150 MCQ, because in one MCQ there are three MCQs are hidden: diagnosis, investigation, treatment. So here they had given you the right likely diagnosis of myeloma, but they are asking the test means investigation, so they are asking which investigation is the best amongst this to confirm the myeloma. So what is the single most accurate test for myeloma? So now you can put your answer in the chat box. So far there is no comments, not a single comment in chat box. So I want, yes, Dr. Ravi, let's start with you. Usually I ask to the candidate who has given the wrong answer. So your answer is wrong, but I want to understand the logic. So don't worry, right or wrong, right? But try to evaluate. Yes, Dr. Ravi, tell me why you think that urine immunoelectrophoresis is the best test.
Uh, Because the Benz Jones proteins are the characteristic of uh, multiple myeloma.
Okay, so do you think the urine test is the most important and diagnostic test or most accurate test for multiple myeloma?
Benz Jones proteins are characteristic of myeloma. So if there are Benz Jones
So,
proteins positive, then it is most likely myeloma.
okay, so say for example, Ben Jones protein is present, then you won't do any test. You directly start the treatment on the Ben Jones protein. Do you know Ben Jones proteins are present in which other condition? This is the only condition where Ben Jones proteins is present, or there is no other differential diagnosis.
So they can be present in leukemia or some types of leukemia.
Okay, so how do you get to know whether this is leukemia or myeloma? So it's a confusing, no? When you are saying it could be leukemia, it could be myeloma. So then what is the logic of doing the this urine immunoelectrophoresis? Then why we should do? Because we are not getting the answer.
So, bone marrow
Yes,
biopsy
Dr.
must be
Jamila. Yes, Dr. Jamila, your explanation. Anyone wants to comment on this?
Yes, I agree with your explanation about Benz-Jones protein is not seen only in multiple myeloma.
Okay, so what are the other condition I would like to know where the Ben Jones proteins are present? And exactly what is the Ben Jones protein? So those who don't know, this is homework. Write down. This is serious class. So we need to totally, absolutely learn the things, right? We don't need to mug up the things. And if you listen me properly, 110% you will learn lots of things. Yes, Dr. Jamila, do you remember any condition where Ben Jones protein is present apart from myeloma?
I can't remember.
No problem. Do you know what is a Ben Jones protein? Can you describe little bit Ben Jones protein?
I think there are proteins that precipitate when the urine is heated at a particular temperature in the lab.
Okay. Okay. So what contains in the Ben Jones protein? Which proteins are present? Or what exactly? I mean, what you call that protein? So those who don't know the Ben Jones protein, your first and foremost homework is to go and read the Ben Jones protein. What is exactly the Ben Jones protein? I will tell you, but don't be lazy. This exam is not easy. Same way it is not hard as well. The only thing is we are not prepared well, right? That is why we have a lot of trouble. I can guarantee you, if you properly read it, the website and MCQs, there are 99% chance that you crack easily, right? But we need to understand we are not understanding. So far, I did not get single satisfactory answer for Ben Jones protein. What is Ben Jones protein? If anybody wants
it is
to try,
a
they
type
try.
of antibody,
Okay,
light chain.
wonderful. So you get little bit point. Absolutely, this is antibody. Now I want to tell which part of antibody because in antibody there are heavy chain, light chain,
Light
right?
chain,
So
These are
yeah, so
light chain
light chain,
proteins.
monoclonal immunoglobulins.
right. So this is how what we do it, right? This is immunoglobulin. This is what we in general. I'm trying to make you understand. So this is heavy
Mhm.
chain and this is light chain, right? And it is attached with the ligands and all blah blah, right? So there are five types of protein: IgG, A, M, D, E. This is a structure of immunoglobulin in general, right? So this light chain is the Ben Jones protein. So what is the definition of Ben Jones protein? So listen it. This is the definition. So Ben Jones proteins are small proteins that are a part of antibodies called light chain. So this is one line. So in general, what Ben Jones proteins are basically proteins. The name itself suggests Ben Jones protein means there is a protein definitely, but Ben Jones is the name of the person. So this protein is basically a light chain, right? This is basically a light chain, right? And it's a part of antibody, right? So Ben-Jones proteins are the part of immunoglobulin, especially it's a light chain and that is released in the urine, and you measure this light chain, and that is called as a urine immunoelectrophoresis, and you find out, right, this. So basically this protein is also seen in other conditions, like one is MGUS. Have you heard of MGUS, monoclonal gammopathy of uncertain significance? Have you heard of this condition, anybody? Yes or no? MGUS, yes or no? Monoclonal gammopathy of uncertain significance. So MGLUS, right? So this is seen in many other conditions as well, not just multiple myeloma. So this is not a 100%, right? So how do you differentiate if it is Ben-Jones protein is present? So how do you differentiate that? Okay, this is multiple myeloma or it is MGUS, right? Then it is confusion. So this, that means this is not very accurate test. It is one of the tests, it's important test, but what they are asking, most accurate, single most accurate. So you need to find out something which is like, if it is done, it is 100%, it is multiple myeloma, then what, then which test could it be?
Bone marrow biopsy.
Yes, bone marrow biopsy, excellent. So bone marrow biopsy, you have done bone marrow biopsy for this patient. What you are going to get in the bone marrow biopsy, tell me? Bone marrow biopsy is done. So what you are looking for in bone marrow biopsy?
Plasma
Answer is
cells.
correct. Answer is bone marrow biopsy. That is answer. Your answer is correct. But I am here not to just mug up the answer. I am here to make you complete concept clarity. So bone marrow biopsy is the correct answer. So if you do the bone marrow biopsy, what you see under the microscope after doing the bone marrow biopsy, what will you see in the microscope? You did a bone marrow
Plasma cells.
examination.
Plasmacytosis
Plasma cells.
morphology.
Okay, plasma cells. What is the normal plasma cells in the bone marrow? If somebody does the normal person's, normal healthy individual, right, right, then what is the normal number of plasma cell? Anybody? There must be number, na? Say for example, normal WBC count in normal healthy individual is 4,000 to 10,000. This is normal. Platelet count is 150,000 to 450,000. This is normal. Same way in bone marrow, there is a number, increased number of plasma cells. So I want to first want you to know what is the number of plasma cells, right? So normal plasma cell in bone marrow is less than 5%, right? Usually 2 to 3%, but it is usually less than 5%, right? So when this plasma cells, what happens in multiple myeloma, right? Multiple myeloma, this plasma cells, right? This plasma cells, they are keep increasing in the number, right? They are keep multiplying. So there is a presence of monoclonal plasma cell, same clone, same morphology, more than 10% of the monoclonal plasma cell, right, in the bone marrow, right, in the bone marrow, it is called as a multiple myeloma. So whether X-ray is osteolytic lesion, have you heard of this osteolytic lesion? Yes or no? At least tell me yes or no. Osteolytic lesion, have you heard of this word?
Yes, sir.
Yes, sir.
Wonderful. So whether osteolytic lesion is present or absent, no matters. Whether 24 hours urine or urine protein, whatever the amount present or absent, serum protein electrophoresis M band is present or absent, and whatever the amount of this urine protein electrophoresis present or absence, if the bone marrow plasma cell is more than 10% monoclonal, it is none other than multiple myeloma. That's it. Shortly, it is called as a myeloma. Full name is, complete name is multiple myeloma. That's it. So this is the diagnostic, right? Even if you have this X-ray normal, 24 hours is not diagnosis, M-band is absent, this is also inconclusive. But if you do one test, and in this one test, there is a more than 10% of the monoclonal plasma cells present, it is none other than multiple myeloma. That's it. Is that clear to everyone? Yes or no? Tell me yes or no. I'm not in
Yes, sir.
hurry. I'm not in hurry. Any questions with this? Right? So don't get confused. So that is why in every bone marrow or every suspected case of the myeloma, we do a bone marrow biopsy. We do a bone marrow biopsy because we need to confirm this is most accurate, most confirmatory, highly sensitive and specific. There are hundreds of words. So if they ask you in the exam, most accurate test, it is bone marrow. They are highly sensitive and specific, bone marrow. Most appropriate test to diagnose, bone marrow. These are the word game. They ask, right? They ask different. They use different word. Either most accurate, highly sensitive, specific, most appropriate, right? Confirmatory test. This is also another word. Confirmatory test for myeloma. You want to confirm 100% that this is myeloma. Again, bone marrow. So you need to stress your mind. You need to be very much smart in the exam what exactly they are asking, right? They may change the word, they probably change you the different word, right? But we don't need to confuse ourselves, we need to pose the perfect answer. Wonderful. Dr. Ravi, let me ask you next questions. How you differentiate between MGUS? Have you heard anyone heard about MGUS and multiple myeloma? Yes or no? Right. So what is the difference between MGUS and multiple myeloma? Monoclonal gammopathy of uncertain significance, right? This is the full form. Monoclonal gammopathy of uncertain significance versus multiple myeloma. Both are under the chapter. If you open up the chapter in any book of blood diseases, plasma cell dyscrasia. So this both will come under one chapter. So both are the plasma cell disorder. So how do you differentiate MGUS versus multiple myeloma? How do you differentiate between MGUS versus Jamila? Any idea?
Gamma heavy chains are more. In multiple myeloma, their light chains are more. In MGUS, heavy chains are more.
No, not
The
mandatorily.
number of plasma cells in MGUS will be between 5 to 10%, and in multiple myeloma, it will be more than 10%.
Great. So this is one of the biggest difference along with many difference. So plasma cell here usually, as I told, less than 5% is normal. 5 to 10% could be MGUS, and multiple myeloma 10% or more than or equal to 10%, right? Monoclonal plasma cells are present. This is one of the biggest, most important criteria, and that is why we need to do the bone marrow examination for all the patients, right? Because by just routine lab, we cannot differentiate between MGUS versus multiple myeloma. So this is one diagnostic criteria. So if I can ask you, what are the diagnostic criteria of multiple myeloma? Diagnostic criteria of multiple myeloma. So one of them
Crab,
biggest criteria is more than 10% of the monoclonal plasma cell in the bone marrow. What else?
crab criteria.
Wonderful. CRAB criteria. So CRAB criteria. So this is a
Yeah.
minor criteria. Presence of any one of this CRAB is okay to diagnose. So you have one major criteria. Major criteria is two, more than
Mm-hmm.
10% of plasma cells in the bone marrow and plasma cytoma on the biopsy. Plasma cytoma on the biopsy. So either of this or this is good enough to diagnose as a one major criteria. And this is CRAB is a minor criteria. CRAB is a minor criteria. So what is the CRAB? C stands for the calcium. Very logic. I'll tell you very logic. You never forget. R for renal insufficiency, A for anemia, and B for bone involvement. So what happens basically when there is an increased plasma cell, right? When this is a bone and when there is an increased plasma cell in the bone marrow, right? What it does cause? Primarily it erode the bone. So when it erodes the bone, calcium will increase in the plasma. So that is the hypercalcemia. So one of them is calcium. So calcium is increased, hypercalcemia. This protein, this protein, monoclonal protein, right? Monoclonal protein, immunoglobulin, na, basically. So it's a protein. So that protein gets blocked into the renal tubules. So renal failure is either because of light chain deposit, because of immunoglobulin, and because of hypercalcemia. So if you open up the book of hyper renal failure, hypercalcemia is one of the cause. So here two cause. Renal primarily one because of protein deposition in the renal tubules plus hypercalcemia because of this, right? Third is anemia. Why anemia? Because in bone marrow, right, this 5% of plasma cell they increase. It will not allow other three cell lines, means RBC, WBC, and platelet count. They will not allow these three healthy cells to form and resulting in low HB, low WBC, and low platelet count. Out of these three striking features is anemia. So patient has anemia and there is a bone destruction. Because of hypercalcemia, bone is destructed. So you can see the lytic lesion in the bone, right? So that is why we do the skull X-ray, and it is very well appreciated well on the skull X-ray. That is why we usually do the skull, but it can seen in other bones as well, not just skull, chest, rib, humerus, femur, but skull is bit more obvious and easily identifiable as well. So skull X-ray we can do. All right. So why we are doing the skull X-ray? To know the bone destruction, or we need to know osteolytic lesion, right? So this can be seen. So this is pathology, right? I told you complete pathology. Why calcium increase? I told you the pathology. Why renal increase or why creatinine increase? I told you, right? Why anemia develop? I told you because of excessive plasma cell will not allow the other normal hematopoietic cell to form, and that is why anemia, leukopenia, pancytopenia, anything can happen, right? And there is a bone destructions as well. So how the patients of myeloma usually present, right? Either they present with a bone pain. So commonest bone is a back pain, means vertebrae and pelvic pain, right? And some patients, I have seen many patients who presents to my OPD for the last many years is a pathological fracture. So they present with the pathological fracture. So first they go to the orthopedic see and they ask the history and he feel that this is not an orthopedic problem. We evaluate and eventually it's turned to be multiple myeloma. So they either present with two things, two bony event, one is a bone pain and another is a pathological fracture. So this is classically presentation of the multiple myeloma. They can present with renal failure, they present with anemia, they present with hypercalcemia, they present with bone pain and fractures as well, right? So we need to compile all the things and we need to diagnose. This is a classical picture of multiple myeloma slides of bone marrow. I did and I seen lots of plasma cells. So this is a plasma cell. Classical. This is a plasma cell. This is a classical. If you remember this picture, you never miss out. Right? So this is a classical plasma cell. So there is an increased number of plasma cells, right? So if you see 100 cells and if it is less than 5, it is less than 5%. But out of 100 cells, if you see 20 cells are plasma cells, means it's 20% of plasma cell. It diagnosed as a multiple myeloma. And these are the classical osteolytic lesion. This is the classical. Can you appreciate yes or no? Can anyone tell me yes or no?
Yes, sir.
Yes or no?
Yes, sir.
Yes.
Right. So this is classical, absolute classical presentations of multiple myeloma in terms of the bone marrow and in terms of the skull X-ray. And this is what the thing is. This is a diagnostic criteria, International Myeloma Working Group. It is shortly known as the International Myeloma Working Group, right? So International Myeloma Working Group, this group is working only for myeloma for many years. I attended the meeting last year in Chicago. I am a member of International Myeloma Working Group as well. So this multiple myeloma, right? They had given the bone marrow biopsy. This is one of the finding where you see the more than or equal to 10% clonal bone marrow plasma cell one, and another is also I told you biopsy proven plasmacytoma. So this is a major criteria on histology. This is a major criteria, right? And this is a minor criteria, right? Shortly as told as a CRAB criteria. So C means calcium more than 11, renal insufficiency, anemia, and bone event. So these are the minor criteria. And two other criteria are also added, biomarkers of malignancy. Even if you have more than 60% of, you need just 10%, but it is more than 60%, it is until proved otherwise myeloma. And serum free light chain as a kappa lambda chain, right, is more than 100, even though it is defines as a multiple myeloma, right? So what you need to diagnose multiple myeloma, you need a one major criteria, and myeloma defining event means one minor criteria, right? So more than 10% of the plasma cell in bone marrow are out, any one out of this, not all four, either calcium or renal or anemia or bone. Even if it is more than 10 plus anemia, it is myeloma. That's it. If all four, prognosis is poor, means bone is bad, kidney is bad, bone marrow is bad, right? That means more, all four crab means all worst criteria. I mean, worst prognosis, right? So crab criteria is very, very important, shortly known as a calcium, renal, anemia, bone. That's it. So this is how you need to remember, right? So this is the these things. Now, how you can diagnose the abnormal protein, because this is a free light chain or globulin, right? Albumin and globulin is a protein. So this is a globulin, right? So this is a normal cow. This is a normal. This is called as a serum protein electrophoresis. Have you heard of this word? Yes or no? Yes or no?
Yes,
Serum protein electrophoresis. Yes or no?
yes, sir.
Right. So when you put this protein and we enter the serum protein electrophoresis, means some kind of electrical generation you start. How they present, this is albumin and this is globulin. So there are alpha 1, alpha 2, beta 1, beta 2, and gamma globulin. This is normal. This is normal cow, right? What happens in multiple myeloma? There is a there is a gamma globulin, gamma globulin, and this spike is also known as the M band. Have you heard of this word, Doctor? M band? Yes or no? M band in multiple myeloma? Yes or no?
Yes, sir.
Wonderful. So this M band is basically a multiple myeloma. So this is a one of the most initial tests. So any patients I suspect, I will not directly go for bone marrow. So how I diagnose in my OPD? So I look at the history, I do the physical examination, I do basic blood test investigations, right? And basic blood test, what I what I how I mean I think of multiple myeloma. Bone pain is present in more than 70-80%. So elderly 50 plus male or female presented with the bone pain, and in basic CBC there is a reduced hemoglobin and increased ESR, and in peripheral smear there is a Role formation. This is absolutely indication of multiple myeloma. So how I do after this? I do serum protein electrophoresis. If I get M band, this is M band on the picture, right? M band. If I see the M band present in this patient, I do all crap. I do serum calcium, I do serum creatinine, I do CBC, and I do X-ray or skeletal survey. If it is positive, then directly I jump to the bone marrow examination. And in bone marrow examination, if I find more than 10% of the things, I'll diagnose this patient as a multiple myeloma. That's it. This is as simple as that. There is no rocket science, right? So this is how you go gradually to diagnose the multiple myeloma. Is that clear to everyone? Yes or no? Tell me yes
Yes,
or
sir.
no.
Yes, sir.
Yes, sir.
Yes, sir.
Wonderful, wonderful, wonderful. Any questions related with multiple myeloma? Any questions? Don't think what the neighbors is saying, what your friend is saying. Don't hesitate to ask any questions. If you miss, then you miss. This is a golden opportunity to ask questions from the expert, real expert.
Sir, can you repeat the investigation for what we have to do first?
Yes. So in investigation, as we know, right? So first we need to do the CBC. So in CBC, what we see, as I told you, crab, one of A is anemia, right? And in advanced case, even you see the reduced WBC and reduced platelet. So basically pancytopenia. ESR usually increased, right? Why increase? There is a reason for it, because there are lots of protein, and this lots of protein will not allow the red blood cell to settle down, right? So ESR is usually high. Erythrocyte sedimentation rate is high, right? Then we do the CRAB, means calcium, serum creatinine, renal means serum creatinine, C for serum calcium, A for anemia, so CBC we already did, and for bone we do the skull X-ray or long bone X-ray. That's it. So if we find one of these things is positive, then I'll directly go for the serum protein electrophoresis. Serum protein electrophoresis, right? Serum protein electrophoresis and serum protein electrophoresis. This called as the M band or myeloma band. Myeloma band. Another name is myeloma band. Seen in myeloma. So myeloma, right? This M band is seen. Then I'll directly go for the bone marrow biopsy, because now this is strong suspicion. CRAB A positive, ESR high, patient has a bone pain, CRAB is present, M band is present. This is extremely highly suspicious of myeloma. So I do the bone marrow, I confirm this number, and I diagnose the multiple myeloma. That's it.
Thank you,
Is
sir.
that clear? Yes or no?
Yes, sir. Thank you, sir. Thank you. Yes, sir.
Right. So this is how the basic flow works, right? And this immunoglobulin, right? He has a free light chain and heavy chain. So we measure both the heavy chain and light chain. So that is what we call as the immune fixation electrophoresis. So we find out quantitative IgG, A and M. We do quantitation, and we do kappa free light chain assay. We called in clinic as a free light chain assay. So there are two free light chain, kappa chain and lambda chain. So we do the kappa quantitative, lambda quantitative. So how our final diagnosis is comes? IgG kappa type multiple myeloma. This is final diagnosis, because there is increase in the IgG, means heavy chain is increased, right? Also kappa or lambda, out of this one in increase, usually not IgG kappa lambda type is not, either kappa increase, because whatever the this malignant plasma cell will grow, it will it will form the antibody. This antibody is formed of one type, IgG lambda, then it is IgG lambda, IgG lambda, IgG lambda, IgG lambda, IgG lambda. If it is processing IgG kappa, then IgG kappa, IgG kappa, IgG kappa, IgG kappa. So same monoclonal, same clonality they will develop, right? So you see the one IgG kappa or IgG lambda, that's it. So this is the final diagnosis. So multiple myeloma means more than 10% of plasma cells, plus you see more than normal IgG, also you see in elevated kappa. So this diagnosis is finally eventually determined as a multiple myeloma IgG kappa subtype. That's it. This is a complete diagnosis of multiple myeloma, right? So that's it. This is how we see. So I don't think so we have to mug up now this topic, how it comes and what we do usually in a clinical practice. Is that clear, doctor? Yes or no? Is that clear? Dr.
Yes.
Maria, is that
Yes,
clear
sir.
to you?
Clear.
Yes.
Any questions to this? This question will ask in exam 100%. Very high yield. It is not a very uncommon malignancy. Multiple myeloma is a common in old age group, and we are seeing a lot of patients from periphery who present with bone pain, anemia, pathological fracture, renal insufficiency. We do bone marrow, and eventually it's turned out to be multiple myeloma. How to do bone marrow and how to interpret the bone marrow. I have excellent video on YouTube, so those who are interested, they can go and check it out. Bone marrow biopsy by Dr. Munjal. So there are thousands and thousands of viewers there. So you can see bit more in detail about the detailed things. So I'm not going much in detail. This is just the schematic presentation. This is a healthy bone marrow and this is a plasma cells. So this all blue is the plasma cells, right? This is plasma cell. So basically plasma cells are increased in the bone marrow. So I'm not going much in detail into the treatment because this is not basically they want to ask you mainly the treatment. This is basically not a part of this GPs. I'm just trying to limit myself because there are a lot more. Otherwise, we cannot discuss any questions. Only myeloma 2 hours is gone. So we'll discuss later on when somebody is interested. Let me know. There is a chemotherapy and autologous stem cell transplant can be done for this treatment. But this is enough for you to know what is multiple myeloma, what is MGUS, how do they present, how you investigate. That's it. This is what the main questions, right, in context to your exams of PROMETRIC. So now very easy, but little conceptualized or concept based questions here, right? So let's jump to the next questions of any questions with myeloma. If you don't ask, means I take it granted that you knows everything now, so you won't have any query. That is why I'm going
Excuse me,
further.
sir. Can you please repeat this immune fixation electrophoresis?
Immunofixation electrophoresis. So immune fixation electrophoresis is basically the name itself. Immune fixation electrophoresis. So it's a immunity or antibody related. So there are IgG, A and M, and another kappa and lambda, right? So this is immunoglobulin chain, right? So there are 10 possibility: IgG kappa, IgG lambda, right? Then IgA kappa, IgA lambda, and then IgM is usually called as a Waldenstrom macroglobulinemia. Waldenstrom macroglobulinemia, if you heard this word. So this can be detected by this test. Quantitative, or another simpler language is a quantitative IgGAM detection and quantitative detection of kappa and lambda. This is heavy chain, this is light chain. So when you detecting heavy chain and light chain, the test name is immune fixation electrophoresis, right? So IgGAM kappa lambda quantitation is done by the test, and the name of the test is IFE, immune fixation electrophoresis. Is that clear? Yes or no?
Yes, sir.
Right. So everyone, I wish everyone to go read once again the multiple myeloma. Any questions? Right. This is my direct mobile number for any hemato-oncology, any query, confusion, directly WhatsApp me on this number.
So one
Try
question,
to
sir.
get back to you. Yes, please.
Sir,
Ask me.
distinguish from Waldenstrom microglobulinemia from multiple myeloma. So only there is no lytic bone lesion in Waldenstrom
Yes. Yes. So
microglobulinemia. So
yeah. So
any other
Walden,
features?
yeah,
Yeah.
I'll tell you. Waldenstrom and multiple myeloma.
Mhm.
So Walden's multiple myeloma, the 90% of the patient I used to see and literature shows IgG and IgA, right? IgM increase, it is called as a Waldenstrom macroglobulinemia. You see IgM, sorry.
Mhm.
IgG and IgA is a multiple myeloma. IgM is usually called as a Waldenstrom. Here
Yes.
crab is very prominent, very prominent. Here crab is not very prominent, right? So you are not seeing much of these things, right? You see low platelet count, you see a bleeding, you see ecchymosis. So platelet manifestations are more here. Number two, right? And in Waldenstrom macroglobulinemia, usually we don't do the bone marrow biopsy. Usually we don't do, right? Only just in case of confusion, when the IgM is borderline, it is not clear cut high. In that case we do, right? Otherwise usually not required. And when required, it is just to exclude the multiple myeloma. That is why we are doing it, right? For Waldenstrom. And here the steroid is the main treatment here. Steroid here is not a primary cornerstone of the treatment. Waldenstrom, we give the chemotherapy with a rituximab based chemotherapy. Rituximab. We have a
Okay.
couple of patients recently diagnosed with Waldenstrom in my OPD. So
Mhm.
rituximab is a treatment, and here VTD, bortezomib, thalidomide, dexamethasone. BTD or BTD, bortezomib, thalidomide, and dexamethasone. This is the name of the regimen. So this is how we use, right? So this is the main differentiating point between the Waldenstrom macroglobulinemia, and it is also very interesting. It is not very common Waldenstrom, but if you get a chance, I think you should read it. It's there in the book Waldenstrom. But I told you the basic differentiating point between Waldenstrom and multiple myeloma.
Okay, sir.
Next questions in front of your screen. It will check your anemia, though it's very common and most, but it will check your anemia knowledge. We'll discuss a lot of things in this. 55-year-old man complains of 4 weeks history of general malaise and fatigue. He has noticed his trousers have become more loose fitting a blood test showing following result. Hemoglobin is 12 gram percent, MCV, that is mean corpuscular volume is 90 femtoliter. Platelet counts are 250,000 per cubic millimeter, WBC is 10,000, serum iron is 10 millimole per liter, total iron binding capacity is 40 millimole per liter, serum ferritin is 160 gram per liter. What could be the most likely diagnosis of his anemia? Let me tell you more specific. Is it thalassemia? Because of that, it is anemia. This is iron deficiency anemia. Because of that, it is anemia. This is anemia of chronic disease. Because of that, it is anemia. This is macrocytic anemia, or this is aplastic anemia. So think over it, post your answers, and discuss why you have this. Think over it. Try to interpret, try to check all your knowledge of hemoglobin, MCV, ferritin, serum ferritin. So this is called as a iron profile. Just for your little bit knowledge, you definitely you are knowing everything, but still I'm trying to give you. So serum iron, TIBC, and serum ferritin. This is called as a iron profile. Iron profile. So what contains in iron profile is three things. Iron profile means obviously serum iron, serum TIBC, that is total iron binding capacity, and serum ferritin, that's it. So these are the numbers. Serum iron is given, serum total iron is given, ferritin is given. So you need to apply all your anemia knowledge here and try to interpret it, and you need to tell what it could be. We have more than 30 doctors in the class, but comment is only 2. Still I'm missing 28 comments. So don't take it lightly. Think over it and think that if the same questions comes in your DHA, HAD, MOH, how you gonna react of this case? You need to do something. You cannot keep it blank in exam. Yes, Dr. Anis, you would like to comment on this? Anything you want to comment, Dr. Anis?
Yes, sir. I will definitely comment on it. Firstly, I film to later. It means that we can exclude from the options like
Yeah, so
macrocytic anemia.
okay, so what do you mean by macrocytic anemia? Let's
Macrocytic means due to folate or vitamin B12 deficiency anemia, and here MCV is greater than 90 femtoliter. So one
okay.
option I excluded was
So more than
A plus.
90, rather I can say more than 100, right? Because
Yes,
80 to 100, just for your knowledge, 80 to 100 is a normal femtoliters. So normochromic normocytic anemia, MCV
and
means in corpuscular volume. So this is absolutely normal. It is not high.
yes,
So
sir.
in
So
macrocytic anemia, the name itself is right. So let me, sorry to bother you. We can discuss with you only. This is normal MCV and the unit is femtoliter. If it is less
yes,
than
sir.
80,
Secondly,
it is called, sorry, 1 second. It is called microcytic, small size. If it is more than 100, it is called as a macrocytic. And if it is the
secondly, we
between
can
80 to
also
100 is a normocytic, right? So by looking towards the number, this is normocytic, this is not macrocytic. Is that clear? Yes or no to everyone? At least tell me yes or no. So I know that, okay, fine, you are with me now.
Yes.
yes, sir.
Wonderful. Now
And
you
we
go,
can
Dr.
also
Anis. Yes.
differentiate. We can also exclude iron deficiency anemia because if it was iron deficiency anemia, it was less than 80.
Wonderful. So if it is a microcytic anemia, usually it is usually less than 80. So microcytic, the commonest less than 80, MCV commonest is iron deficiency anemia. And here the commonest more than 100 is a B12 and folate, for your knowledge, right? This is how we have to remember. And normochromic anemia, number one is anemia of chronic disease, right? This is the most common. Second is a hemolysis. There are a lot of causes, but these are very common in our clinical practice. I can make long list, but this is just for your knowledge. So iron deficiency is also gone by the exclusion. So iron is gone, B12 is gone. Now we have three options. Now if we want to exclude Dr. Anish thalassemia, how you gonna exclude this thalassemia?
Sir, the serum ferritin 160, is this normal? 160 gram per liter?
Yes, it is normal.
So it is generally
Plus,
microgram like that.
yeah.
Sir, exactly. I do not remember the exact iron profile, the values of iron profile. That's why I'm a little bit confused. Baki, rest of we can also exclude aplastic anemia because the cells are not too much low, so we can exclude from aplastic
Okay, so
anemia as well.
aplastic anemia, I keep her name in old books. It is aplastic pancytopenia, right?
Yes, sir.
Yes.
Aplastic pancytopenia. My word
Yes.
I teach to my student and my resident as aplastic pancytopenia. Why? Because it's not just low HB. Whenever we see there is a low HB, low platelet count, and low WBC as well. So they usually present with pancytopenia. But for many years and years in book, it is a aplastic anemia. So we keep aplastic anemia. What point favor against again
Uh,
aplastic anemia? 1 second. No? It is pancytopenia, which is not there. It's a disease of mainly more in female of 20 to 40. That is against. This is a male, right? This is what we need to remember. We don't need to mug up. So this is against favor. This age is against little favor. Third things. Normally in aplastic anemia, if you go and review the literature, MCV is usually high or it is a cause of macrocytic anemia. So B12 folate, aplastic anemia, hemorrhage or hemolysis, right? These are the common cause of macrocytic anemia. So this is not a macro, this is normal. 80 to 100 is normal. He has 90. So this is against aplastic anemia, right? So these are the things. Now you have two things. Thalassemia is left and anemia of chronic disease is left. So how you exclude that thalassemia now? What are the point not favoring to the thalassemia?
So in thalassemia also we
Comparatively
see, so in thalassemia
age.
also we see MCV less than 70 microcystic. It
So
will be in the list of microcystic.
and
okay,
if
so
there is
so
thalassemia, there is also a scenario of bilirubin type.
fine,
Uh,
fair enough. So thalassemia minor and major, there are two things. So major is absolutely out of questions because very rarely there is no history of recurrent blood transfusion in the history. So major is gone. There is a the patient up to 55 years of age patients not diagnosed with thalassemia major is quite impossible. I have not seen in my practice. Because they when there is a thalassemia major at the age of 1 year or the first birthday they present with the 5 HB and they diagnosed as a by doing hemoglobin electrophoresis they diagnosed as a thalassemia major. That's it. Sorry. So this is not the age to diagnose thalassemia major. No history of blood transfusion recurrent, so it is gone. So it could be minor, but why it is not minor? Few example, right? Number one, thalassemia minor, you have microcytic anemia. So another three causes of microcytic anemia were less than 80 MCVs. One is iron deficiency anemia, number one. Number two is hemoglobinopathies or thalassemia, and third thing is anemia of chronic disease. So anemia of chronic disease, they have a normochromic first, normal MCV, but
Yes.
eventually they go into the microcytic. So MCV again go down. So these are the common causes, right? So here the MCV is not low, right? And there is no family history of thalassemia minor given. So that is against thalassemia minor up to 55 years of age, not diagnosed. That is also, and right. So these are the point against this thalassemia minor. So what the things is remaining is a anemia of chronic disease, right? So this could be the anemia of chronic disease could be the diagnosis. Now, Dr. Anish, I
Sir,
want to know the
can,
no 1 minute, 1 minute, 1 minute. I
yes,
want
sir,
to
yes,
know
sir.
Dr. Anish head-to-head comparison. Let me say iron deficiency anemia here and here anemia of chronic disease. I want to know three things: serum iron, serum ferritin, serum TIBC, transferrin saturation, right? And soluble transferrin receptor, if you heard. So this is little new for you probably, but I want to know what is the head-to-head comparison. What is there? Increase, decrease, increase, decrease, increase, decrease, or normal? What happens in iron deficiency anemia with iron profile? Means this three thing is known as iron profile. Now tell me.
Serum
See,
iron will
this
be
is
definitely low.
Low. Low. Okay, fine. This is 100% confirmed. Iron deficiency anemia, iron is low. What happens to ferritin and TIBC?
Ferritin is also low, TIBC is high.
Ferritin is also low. Ferritin is
Ferritin
also
is
low.
also low. Okay, fine. Ferritin is also low. And TIBC?
Increase. It will increase.
Sorry?
Total iron binding capacity will increase.
Increase. Okay, fine. So that's it. This is one the picture of iron deficiency. Now, how it differs from anemia of chronic disease? Because until and unless we do in the clinical exam, I mean clinical practice, right? We do iron profile. How do we get to know that okay, this is iron deficiency or what? This is the one of the marker, or this is the one of the good test by which you at least get the idea that okay, fine, this is iron deficiency going more towards iron deficiency or anemia of chronic disease. So what happens in anemia of chronic disease? All three things. Now tell me, Anis, any iron serum iron what? Normal, increase or decrease?
Uh, decrease.
Low,
It
So
sir.
will.
I can I
No,
can
sir.
say
Low.
normal and or decrease or
Decrease, sir.
decrease. Okay, fine, fair enough. Ferritin, what happens to ferritin?
Normal.
So there are two things,
Increase.
normal or high, normal or high. So what is the take home message? Absolutely not low, right? Absolutely not low. So there is only one differential diagnosis in this world when there is a low ferritin. आंख बंद करके बोल दो iron deficiency anemia. That's it.
Sir,
When
I do
ferritin
not
is low,
understand in anemia of chronic disease how serum ferritin may increase. I do not
I'll come
decipher
on
that.
that point. Right now, I'll come. So, anemia of chronic disease, the name itself suggests. What do you mean by anemia of chronic disease? So, because of any chronic disease in your body, right, it will not utilize the iron well, and because of that, there is an anemia develop. Few example for your understanding. Chronic anemia of chronic disease. So, there must be some chronic disease. Chronic renal failure. This is one disease, right? Chronic liver disease, another disease. Chronic hypothyroidism, chronic disease. Is that clear? Chronic
Yes,
malignancy. Are you getting me? At least tell me yes or no.
yes, sir.
So, because of this all chronic condition, what happens? Your body has either normal iron, your body has a normal ferritin or even high ferritin. They cannot be utilized to form normal healthy red blood cell, and that is why they have anemia. So it is a very important and interesting, right? Your iron is normal, your ferritin is normal, but there is no formation of hemoglobin. Why so? Because in this because of this chronic disease, there is a lots of inflammations going into the tissue, and that hampers the that hampers with the transportation of iron and ferritin to form the hemoglobin, right? So, in spite of having
Roll
even
sound.
forget about normal ferritin, even high ferritin store is quite good, very nice store of your iron in your body. It is measured by the ferritin. What is ferritin? Ferritin is basically the iron store. So, if you have
Yes,
normal or higher store, even though your hemoglobin is not formed, because they are not utilizing well because of chronic inflammations in the body, right? So that is why the anemia develops, right? And this is what happens. And to TIBC, it is low. So these are the two differentiating point between anemia of chronic disease and here is high. So what is the change? TIBC is high in iron deficiency. Here TIBC is low in iron deficiency. Ferritin is low and ferritin is normal or high. So iron you cannot differentiate because in both the condition it could be low in both the conditions. So by iron you cannot diagnose. So if you want to differentiate anemia of chronic disease versus iron deficiency anemia, the first test you do the ferritin first test, right? So if the ferritin is low, your chapter is over completely. You don't need to do any other test. Irrespective of what iron and TIBC comes, low ferritin means iron deficiency. That's it. This is the diagnostic point, right? But what happens? One clue, when there is a fever, there is an infection, when there is an inflammation in the body, this ferritin is called as an acute phase reactant. And in this condition, this will release this ferritin from the macrophage in the body, macrophage. And because of that, it falsely elevate for some time. So in spite of iron deficiency with fever, you have normal ferritin. Why? Because of fever, infection, inflammation, lots of ferritin or macrophage release this into the blood, and that is why in spite of iron deficiency you have normal ferritin. So when patient is healthy, when patient has no infection, fever, inflammation, patient is absolutely fine, that time is the best time to do the ferritin, right? But what else?
Yes, sir.
If patient comes with a fever and you want to diagnose, then you do the TIBC. If TIBC, this is not acute phase reaction, not acute phase reaction. So in spite of fever, or in case or instance, if there is a fever, infection, inflammation, it will not change. It will not elevate or reduce because of this underlying condition in the body. Whatever the exact amount is that it will show. So even though the ferritin is normal or high because of fever in iron deficiency, TIBC increases. Again, that is a signs of iron deficiency anemia. So ferritin can be falsely elevated in infection, inflammation, and fever. Absolutely clear cut written in the book, and we have seen practically in my practice. I intentionally do the ferritin in fever, and usually they are high. And after do it after 1 month when patient is fine, that ferritin is absolutely low, and I diagnose this is iron deficiency. Why it was elevated 1 month before? Because at that time patient has fever, infection, inflammation, something autoimmune going on. So there is a hyper reactivation of macrophages because of underlying body process. That's it. So this is what the thing is. And can anyone tell me how to calculate the transferrin saturation? Can anyone tell me what how to calculate transferrin saturation?
So,
Anyone?
so serum iron by TIBC. It is a ratio.
Excellent. So what is the normal range? Transferrin saturations. So transferrin saturation, as rightly told, serum iron divided by TIBC. This is called as a transferrin saturation. It is in the percentage. It is in the percentage. Normally it is 20 to 50%. So if anything is less than 20% in our clinical practice, we called as iron deficiency anemia. So this is again another good criteria where the ferritin is not there, acute phase reactant is not there. So whatever serum iron, right? So say for example 100 and TIBC is 10. So total is 10%. So 10%. Anything less than 20% is iron deficiency usually. So this is excellent criteria. So you should also check for the transferrin saturation, and this report will be given by the lab. So you don't need to stress and worried. But even the lab is not giving, you can calculate by your own by trans serum iron divided by TIBC. So now concluding our talk, this is absolutely a iron deficiency anemia. This is the clear cut chart here given in schematic way. Excellent chart. So here as we discussed, right? No need to mug up anything. If you remember, MCV is low, microcytic anemia, because iron deficiency is a microcytic anemia. I created one acronym, microcytic. So any microcytic means what? 80 to 100 normal and less than 80 is a microcytic anemia. So there are four differential diagnoses. I created one acronym, iron last. Write down in your note. Iron last means this is last iron. In short, this is how you can remember. So there are five words, iron and last. So iron means iron deficiency anemia. So this is one cause. L means lead poisoning. Uncommon, but you see the microcytic anemia. A means anemia of chronic disease. Very common second cause. S means sideroblastic anemia. Sideroblastic anemia. Uncommon. And T stands for thalassemia. So all three comes. Iron last. So this is remember first word. Iron last. LAST. Iron last. This is I think the most simplest form I am giving you. Iron last. So whenever I come to in my OPD when MCV low comes, any patient comes with the low MCV, I remember and try to rule out iron last. That's it. I look one by one. Is it iron deficiency? No. Is it lead poisoning? No. Is it anemia of chronic disease? No. Is it sideroblastic by doing bone marrow? No. Is it thalassemia? No. So you can get any of these things. Not all the no, obviously, right? So you need to rule out one by one. And whenever any low MCV comes to your practice, there are two most important differential diagnoses. Number one, in clinical practice across the globe, I'm telling in general, especially in a developing country, iron deficiency, anemia of chronic disease, and hemoglobinopathies or thalassemia. Lead poisoning from iron last and sideroblastic is very uncommon, not very common. These are extremely common, and this is second most common. This is how we see in many years in my practice. So I mean, I practice in various part of the world, so everywhere look by and large the same, right? So basically, this is how you remember. Would did you like this iron last? Yes or no? Anyone?
Yes.
Did you like this iron last or no?
Yes.
Yes, sir.
Great. So this is most easiest form now. So any low MCV, you don't need to mug up. Iron last, that's it. You need to rule out one by one. That's it. Right. So this is here again, the chart is self-explanatory. So MCV is low, obviously low because it is a microcytic anemia. Iron is low, iron deficiency, obviously iron is low. Right. TIBC is high, as we told. Total iron binding capacity, ferritin store is low, and transfer in saturation. Iron divided by TIBC is low, less than 20% TIBC, as I told you. So right, so this is one common, and another common is anemia of chronic disease, right? So again here you see MCV initially normal and then eventually develop microcytic anemia. Iron is low in both the condition, right? So you cannot differentiate. Iron is low, here low iron, here low iron. So how do you differentiate whether it is iron deficiency or anemia of chronic disease? Then look at the TIBC. See either
Yes.
TIBC, it is increase here, it is decrease here. And another, ferritin is low, and here ferritin is usually high. By my experience, usually high. It could be normal, but 100% it is not low. So these are the differentiating point between this. So you need to completely concentrate on the questions. You need to understand the basic. You don't need to mug up. And this is what the thing is. This is a excellent chart. I got it from the Ambos this courtesy. So microcytic, as I told you, less than 100, normocytic 80 to 100, macrocytic more than 100. That's it, right? Mechanism, as we seen, right? This is the same what we discussed. So these are the various causes of this. So not going much in detail, right? So anemia of chronic disease. What anemia of chronic disease? Anemia due to chronic inflammations or chronic malignancy. Second most common anemia. Second most common anemia. First most common is iron deficiency. Second most common is anemia of chronic disease. Pathophysiology is also given, but we don't need to remember. Etiology: chronic inflammations, chronic malignancy, chronic infections like tuberculosis. So anything, any chronic disease cause anemia, it is called as anemia of chronic disease. That's it. And diagnosis, right? Earlier it is normal MCV, and eventually it is a microcytic, so low MCV, low iron, right? Low this low TIBC, TIBC high in iron deficiency, normal or high ferritin. So reverse. So nothing, no need to remember. And treatment is what? Treat the underlying cause. That's it. In severe cases, blood transfusion or erythropoietin. So this is again a very important clue here. Erythropoietin. So erythropoietin is helpful in anemia of chronic disease. It is not required in iron deficiency, because in iron deficiency everything is fine. Just iron is low, so supplement the iron. That's it. Here iron is normal, ferritin is normal or high, but they are not utilizing well. So this erythropoietin may help. Yeah, so that's what the thing is. So this is anemia of chronic disease. So you, Dr. Anis, what you need to do, you go and see the normal range, right? I will share this PowerPoint with you later on with everyone. Go on our YouTube channel. By night, it will be uploaded, same whole complete videos of this, right? So this is
Okay,
what the
sir.
thing is. Is that clear to everyone? Yes or no?
Yes, sir.
Yes.
Anyone has any doubt regarding this?
So one question, so anemia of chronic disease, again, the presentation acute and late. So we have to distinguish this one.
Sorry, can you repeat, doctor, please, question?
So anemia of chronic disease, again, there is a differences in acute presentation and late presentation.
It's there. Anemia of chronic diseases itself is a chronic disease. The name itself suggests, right?
Yeah.
That is why the name comes, na? Anemia of chronic disease. It is not anemia of acute disease, anemia of chronic disease. So, because of underlying chronic disease, you have anemia, right? So, you need to just check on the history. So, what happens? So, here not given in the history, but in history, sometimes what they
Sir,
given? Patient,
I was
one second,
interested
patients
on
of chronic
something.
renal failure, patients alcoholic and chronic liver disease, patient has a chronic hypothyroidism, patient has a chronic anemia and eventually develop aplastic anemia, blah, blah. So there must be something clue in the history, and that should be followed by the iron profile. So you need to look on the iron profile. What's the iron profile is there, right? So on that
Sir,
you will differentiate from iron deficiency anemia to anemia of chronic disease, which is what we did it recently, right? So you
Yeah,
need
yes.
mainly on
sir,
the
in recent example, there was also a clue of weight loss, loose fitting of his cloth.
Chronic disease, any chronic disease, you get the, I mean, the constitutional symptoms, weight loss, reduced appetite, or history of chronic bleeding, chronic GI bleeding, right? Chronic bleeding per rectum, chronic melena. This is what? It is chronic blood loss of colon CA, ulcerative colitis, Crohn's disease. That is again a here inflammatory bowel disease. That is also a disease,
Yeah.
inflammatory bowel disease. It's also anemia of chronic disease. Absolutely. Is that
Okay.
clear? So
Yeah,
any
yeah.
chronic condition, right, which leads to anemia is called anemia of chronic disease, where
Mhm.
this will help you to differentiate between this. Is that clear?
Yes, sir.
Yes,
Madam,
sir.
is that clear?
Yes, sir.
Yeah. Yes, sir.
Wonderful. Wonderful. So don't do mistake in the exam. 29-year-old woman complains of tiredness, especially during the activity. On examination, patient appears pale. Ore rods and cystocytes can be seen on the peripheral smear. The patient is referred for a bone marrow biopsy and excreted cells are sent for the cytogenetic analysis. Most likely results are what you can expect in the result in cytogenetic. There is a translocation 12, 21, 15, 17, 9, 22, 14, 18, 8, 14, and 8, 21. Your time
C.
starts now.
Sir.
You post your answer
It's
in the chat
15.
box. We'll discuss. We'll
Okay.
discuss. Everyone post your answer in the chat box. We'll discuss. We are more than 30 doctors, so let's see. Only one or two comment will not suffice. I need at least 5, 10 comments. I want everyone to try. Don't expect in exam all lollipop questions. Post everyone the answer, otherwise I tell the name. Dr. Yalini, any comment, Dr. Yalini?
Yes, sir. I think it's T1517
16 is
B.
nowhere in the option.
B 1517.
15, 17. Okay, fine. Let's see. So I'll keep your answer. So you can post. You did not post it, so I thought you. Fine. So you post your answer. Dr. Nisa Lal, Dr. Saida Zara, Dr. Mitu Maria Madan Lal Gupta, Jamila. What's your answer? Post your answer. You need to think up well. Yes, Dr. Yalini. So tell me one by one. Let's start. Are you okay to discuss, Dr. Yalini?
Yes, sir.
Wonderful. You will learn a lot of things. Huh? In one questions, probably 10 things you will clarify in next 5 minutes. So now, first of all, tell me, all rods is present in which AML?
Acute promyelocytic leukemia, sir.
Wonderful.
Yeah,
Super. Brilliant. AML, M3 subtype,
22.
Yes.
also name is APL, acute promyelocytic leukemia. Just for your knowledge, this is more commonly seen in APL, but it also seen in other AML as well, right? So not
Yes.
just APL. It is more frequently seen in APL or AML-M3. Both are the same thing, but it can be seen in AML. So what's your take-home message? Write down in bold letter. No need to confuse. Or rod is equal to AML. Means if or rod is present, means no CML, no CLL, no ALL. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Whenever don't get confused, they sometimes give you the picture. This is a picture MCQ as well. Another way of presentation. This is or rod. This is or rod. It's already rod. This is a cell. This is nucleus. And in the cytoplasm, this is cytoplasm, there is a rod-like structure. This is called as a or rod. And there are too many or rods together. There is a one term. Can anyone tell me what's the term? Dr. Neeraja,
Yes,
if
sir.
there is
It's
a,
faggot cell.
it's called as a faggot.
Yes, sir.
Faggots.
Faggot.
So it is called faggot. So when there is a scattered or rod, it is or rod, but there are 10, 20 or rods together, lots of or rods together. The word is faggot in the book, right? So or rod or faggot, this is AML. No need to confuse, nothing, no differential diagnosis. So or rod is AML. That's it. Number one, MCQ in the exam. Second questions, right? When you or rod is there means what? You are dealing with some AML. Bone marrow examination you have done, commonly or seen in APL M3, right? So APL M3, what cytogenetic, what cytogenetic abnormality you see, and what oncogene you can see, and what treatment you give against this oncogene? Three questions, doctor. Tell me, doctor, first of all. Yalini, tell me, what cytogenetic abnormality in AML M3 or APL? Sorry.
So,
Yalini.
so APML, we see like the fusion of PML and RAR alpha.
Excellent. So cytogenetic abnormality is a translocation between 15 and 17. So for people doesn't know what is a translocation. So let me tell you, cytogenetic is a chromosomal analysis. Two name chromosomal analysis is equal to cytogenetic. Both are the same thing, synonym, cytogenetic. Cyto means cell and genetic is a genetic material of the cell. That is called cytogenetic, cell genetic. Cytogenetic, that is chromosome. What is the genetic of the cell? So this is a cell. This is a nucleus, right? And within the nucleus, there is a chromosome. So when you do multiplication and you do, right? So there is a, right? There is a 23 pairs of chromosome. Have you heard of this? Yes or no? 1, 2, 3, 4, 5, 6, 7, blah, blah, like 323 pairs of chromosome. Yes or no?
Yes, sir.
Yes, sir. Yes, sir.
23rd pair of chromosome is called as a sex chromosome. How you determine sex of male? If it is XY, it is male. If it is XX, it is female. Yes or no?
Yes, sir.
Right. So now again come to the basic. There is a translocation of 15, 17. Means there is a 15 number of chromosome and there is a 17 number of chromosome. There is a translocation. So some part of 17 is going into the 15 and some part of 15 going into the 17. It's like BCI, it's like translocation in 922 Philadelphia chromosome. Right. Same thing, same Philadelphia chromosome in CML, right? So some part of 15 is going here and some part of 17 going here. So it is called translocation. Trans means exchange. Transfusion. We remove the blood from one patient and giving to the transfusion. Transplantation. So we remove the kidney from one person and given to another person. Kidney transplantation. So we get the kidney from donor and giving to the recipient. Transfusion. So we take blood from one donor and given to the recipient. Same way, translocation. Location. Trans means change. Translocation means location is change. 17 location is in 15 and 15 location in 17. This is called translocation. So this is 15, 17 is the commonest cytogenetic abnormality in APLM3. That's correct answer. Perfect, Yalini. Now what oncogene will develop because of this translocation? There is one abnormal gene or abnormal this long arm This is chromosome. If you forget, this is short arm and long arm. I probably draw the reverse one, right? So this is upside down, right? So this is chromosome, right? So what oncogene will develop? What oncogene will develop with the translocation of 1517? Yalini, you told perfectly right. PML RAR alpha,
Yes, sir.
right? And what treatment you give for this AML? These three are the high yield question in exam. ATRA, all trans retinoic acid, all trans retinoic acid. So in one questions we decided, we did the three questions. What cytogenetic abnormality APML M3 seen, translocation 1517, what oncogene PML RAR alpha, what treatment ATRA. That's it. This is what you need to know. High yield. You don't need to do PhD in AML. That's it. Leave it. Now tell me, Dr. Yalini, you only tell me this translocation 920T is 22 is seen in which condition? Number one, diagnosis commonly. Which condition you see the translocation 922?
ALL, sir.
No ALL. More common than ALL is
So
CML.
PML.
CML
CML.
missing.
CML. So in CML, here this part is AML. This is CML. Again, cytogenetic abnormality 922. Oncogene BCR-able. Is that correct? Yes or no? Treatment imatinib. Yes or no?
Yes, sir.
Yes, sir.
That's it. This is high yield. That's it. This is high yield. Right? What they ask. So two things. This is the most common they ask in the exam. Let me go little third one. Anyone has any idea what about 14 and 18? Anyone has idea about 14 and 18?
So 14 is to 18, sir. Yeah, and diffuse large B cell lymphoma and follicular lymphoma in these two
Wonderful,
conditions.
wonderful, wonderful. Follicular lymphoma can be seen. And 814,
Sir,
814.
so Burkitt lymphoma.
Wonderful, wonderful. Burkitt lymphoma. 821 and 1221. So far, I'm happy. You did excellent, good job. So far, everyone did good job. I'm very glad, very glad, very happy. So here, just for the sake of the answer, this is AML, right? Where you see the lots of OR rods or rods are in the plasma. This is looks like AML with OR rod. It is likely APL. And what they are saying, right? The bone marrow examination done and excreted cells are sent for the cytogenetic analysis. So what cytogenetic analysis you are expecting in APL-M3 is translocation 1517. Oncogene, if they ask, the answer is PML RAR alpha. Treatment, they ask ATRA. That's it. So let's see. This is an excellent picture. I got it from another international book for you to understand. So this is super duper picture. Super duper picture. T translocation 922 BCR-able hybrid gene, as I told you, or you can see oncogene, which hybrid gene. Why this is hybrid gene? Because hybridization of 922, 9 part going in 22, 20 part going in 92. That T stand for translocation. Wherever you see T is translocation, right? So it is seen in commonly in CML and very less commonly in ALL. So CML, remember, it's good enough. This is common. Again, what we are saying, T1517, that is our MCQ, promyelocytic leukemia, shortly called as acute promyelocytic leukemia or FAB classification AML-M3. That's it, right? What AML-M3, it is written already here, acute promyelocytic. So our two questions solved. Again, there is a 814, as doctor rightly, excellently said. The name is Burkitt lymphoma. Burkitt lymphoma. And what is the gene affected? CMYC. We called as a CMYC shortly. CMYC activation or CMYC. Right? Then 1418. Again, she told excellently well. Follicular lymphoma. Right? 1221. Right? This is BALL. You don't need to remember everything, but just for your knowledge, I'm finishing it off. 1114 is mantle cell lymphoma, again comes under non-Hodgkin's lymphoma, right? So that's it. So what you need to remember, number one is 100% you need to remember 922 BCR-able, imatinib is the drug. Second most important is this 1517, where is this is APL. You must remember Then you need to remember this Burkitt's lymphoma. Third number, this is exam point of view because I'm solving this MCQ for more than 10 years now. So I know what they ask in exam. That is why I'm giving you the high yield points. And this is follicular lymphoma. This four you must need to remember. That's it. If you don't remember other, it's okay. But these are the commonly asked questions in the exam. Is that clear? Yes or no? Tell me yes or no.
Yes, sir.
Yes.
Any confusion?
Nothing, sir.
Wonderful. Wonderful. Very interesting. You guys are tired or stop or I'll go one or two more questions.
More questions. One or two more.
Sorry?
One or two more.
Wonderful.
Sir, we
Good
are
energy
interested.
level.
Go with
Yeah,
two
yeah.
or three
Wo-
questions.
Wonderful. Wonderful. You all are very brilliant. You all expert. This is another questions, but just for your knowledge, this CML, how it evolves, right? Formation of Philadelphia chromosome. So this is normal chromosome 9. This is normal chromosome 22. So one part of 22 is BCR and one part of 9 is ABL. So this is oncogene. So there is a translocation in cytogenetic is 922 translocation and oncogene is BCR-able. So translocated this chromosome is called as a Philadelphia chromosome, that is translocation of 922 and gene develop is BCR-able. If you block this BCR-able, you stop the CML and the drug of choice to block the BCR-able is imatinib. That's it. This is the complete schematic presentation. This is nice picture. It applicable to all translocation. Just number is changed. 922, 15, 17, 14, 18, 11, 21, that's blah, blah. But the logic is the same, right? So you need to remember. You need to remember. Patient comes with ITP and platelet count is 5,000 per cubic millimeter. The patient has epistaxis patechi as well as intracranial hemorrhage and melena. What is the best initial step? You start prednisone, you go for bone marrow biopsy to confirm it. You do antiplatelet antibodies because it's very low. You do sonogram and try to find out what is the spleen. You ask for the hematology consultation because this looks 5,000 platelet very critical. Something goes wrong, so you want to do it. And F is IV immunoglobulin. So first I would like to ask Dr. Nasreen, what is your answer? Think over it, but
So
tell me
answer
the
is
answer.
C, sir, antiplatelet antibodies.
Wonderful. Let me answer. So first three things. If you remember my chart in your exam or in your preparation, you will be an expert of MCQ. So Nasreen, doctor, tell me what is the diagnosis of this patient first of all. Without diagnosis, you cannot do anything.
The ITP immune thrombocytopenia.
Okay, immune. Earlier, its name is idiopathic thrombocytopenic purpura. Earlier, but now it turned to be immune because there must be some kind of auto antibody developed. So immune mediated. Okay, fine. Because they already told you, right? It is a ITP. They had given the diagnosis. The patient comes in with ITP, right? And platelets are low. That is ITP, right? So
Yeah.
now, if you want to investigate or if you want to do the next initial step, what they are telling is what is the best initial step in the diagnosis. So now
Sir,
what is the
go
initial
for
step? 1 minute, brother. Let her ask 1 minute. Yes,
So I
yes.
this much remember sir, ITP due to defect in antibodies GP2 3A, defect in anti GP2B 3A antibodies. There will be consumption of platelet. For these reasons, the platelet goes low.
Fine. So you want to basically your logic is you want to do the antiplatelet antibody, right?
Yeah, sir.
Okay. So now next question. Antiplatelet antibodies you did and antiplatelet antibodies are positive or present. What will you do? Now same question. What is the next initial step? Best initial next step. Now what's there? Here I add one more line. Patient tested for antiplatelet antibody and antiplatelet antibody is positive. And the now question is, what is the best initial step? Now what you want to do? Let her ask, let her ask. I will ask everyone, don't worry. Yes, yes, Dr. Nasreen.
So, so we should manage the patient first.
Yeah, so what you would
Usually,
do? From options you select something, na? That is why we are discussing here, na? Because if I discuss, then you can answer 10 questions, because it's not possible that they will ask same copy paste question in your exam. They probably ask something else. And that is why I'm explaining in detail, because anything they ask, you can answer. Yes, Dr. Yalini, why you want to consult hematologist? Dr. Yalini.
So, I'm thinking like since the patient currently has bleeding, we might have to go for IV immunoglobulin. So, but as an initial
Your
step,
answer
it's
is
best.
you posted the answer hematology
Yeah,
consultation.
yeah. So, but then initial step, sir, I think we would go for the hematology consultation where they can
Oh, so
take the
you decide
decision
the
to get the
answer.
patient.
If the same question comes in exam, what you decide? E or F? In
E, sir.
exam, E or F?
the F, sir. I
No, no.
know.
I'm asking
E,
Yalini. Forget about everyone. Yalini, what you select?
E, sir.
Sorry,
E for hematology consultation.
I write down Dr. Yalini. Okay, we'll discuss. Now, let me ask you, Dr. Yalini, why you want to consult hematologist? What hematologist will do the miracle in this patient?
So that they can take the decision
You can also take a decision. Na? You don't need hematologist. You are hematologist. My residents are taking decision. They are not calling me, sir, 5,000 platelet. They are taking decision. What to do? Because hematologist is busy guy. He's a big shot. He may come, he may not come immediately.
Mm.
Yes, Anis, you also posted hematology consultation. Any comment on hematology consultation? What you
Uh,
want to prove by consulting? Because consultation
sir,
means he will come see the
yeah,
patient and he will tell something. So what you are expecting?
Steroid. Uh,
sir, if I was independent to make decision, I would have transfused platelets and make the bleeding stoppage stable. Then I will go further
I
for
think it's steroid.
hematology consultation. But
Okay,
here
but
is not given the
so say for
option of
example, I remove this option. If this option is not in the exam, what will you select?
platelet
1 minute.
transfusion, sir.
Nasrin, I am coming to you. Yes, tell me, Anis. If this A, B, C,
Platelet
D, and
transfusion.
F is option, E is not in option, what will you select now, Anis?
Platelet transfusion, definitely, sir.
Platelet transfusion. If the platelet transfusion is not in the options, what will you do? This is the same
Fresh
question come in
frozen,
your exam.
fresh frozen plasma, FFPs.
No, no, no. You have to select my brother from A, B, C, D, and F. You select one. No platelet,
Uh,
nothing in option.
I will go for IV immunoglobulin or prednisolone.
No, so you need to select among A or F then. There is no two option in exam. No exam has two option. Only one. You have to select
I will
only one.
definitely select option A, sir.
Option A. Okay, fine. Wonderful. So this is Dr. Anis. Fine. Yes, Dr. Nasrin. You raise the hand. Tell me.
So my answer is also first prednisolone, second will be IV immunoglobulin, and third will be splenectomy for refractory ITP. So these I remember like from the book text, but
Fair enough. Fair enough. Fair enough. Fair enough. Any other comments from anyone from
When
house?
platelet count is above 20,000, we go for prednisone, and if it is less than that, we go for IV immunoglobulin.
So platelet numbers are the one which decide steroid or IV immunoglobulin.
Yes, sir.
Okay.
Sir, any basically life severe bleeding, GI or CNS bleeding, we have to give IV immunoglobulin, sir.
Excellent. Wonderful. I think you attended the last session. Wonderful. Any other comments in the house? We are 30 doctors. Dr. Joanne, Dr. Maria, Dr. Mitu, Dr. Neeraja, Dr. Priya, Dr. Saida. There are lots of doctors. Any comment? These all are exam absolutely high yield questions in exam.
IV immunoglobulin.
IV immunoglobulin. Why IV immunoglobulin?
Sir, here is the severe bleeding is there. It is melena is there. Intracranial hemorrhage.
Okay.
And the platelet count is less than 10,000. So we have to go for IVG.
So she is brilliant. So let me tell you the story of ITP. Probably we'll stop late then. ITP, that is immune thrombocytopenic purpura. Indication of prednisone. It's a first line treatment. First line treatment, especially in a non-life threatening bleeding. Non-life threatening bleeding. That means there is a one another question, sir. What do you mean by life threatening bleeding? Then come to life threatening bleeding. I remember 3B. Life threatening bleeding B, bowel B, bowel, brain B. Bowel bleeding means melena, brain bleeding means intracranial hemorrhage. So when the bleeding in bowel, massive bowel hemorrhage, massive intracranial hemorrhage, the first and foremost indication is IVIG. And third indication, life-threatening bowel, brain, and platelet count is less than 10,000. In that case, this is the fastest things which increases the blood pressure, blood platelet count, and it probably stops the bleeding. So in case of brain or intracranial hemorrhage, as our question what says, intracranial hemorrhage, clear cut it is written, intracranial. And intracranial hemorrhage, forget about 5,000, even it is 20,000, I will give IVIG. This is one of the bad bleeding in the body, especially with the low platelet count. And especially 5,000. You see the number so scary. 5,000 means very scary. Scary for doctors, scary for relatives. Right? So you have a very,
Hello?
very less than 10,000 is scary number.
Doctor, are you in
On
clinic
top of
now?
that, you have
What time
intracranial
are you
hemorrhage.
there, sir?
Steroid will take
Just one minute, sir.
the time to increase the
Sir,
platelet
patient at
count.
ICU.
Right? I will mute all because I won't get disturbance. I don't need a disturbance. So I muted all. So basically, this bad bleeding, intracranial or bowel, first and foremost treatment is immunoglobulin, right? Say for example, here I remove this, just epistaxis and patechy, no intracranial and no melena. Probably my answer is a prednisolone. So in case of life-threatening bleeding, when you want to, say for example, patient has a splenic rupture, patient is known case of ITP, right? Known case of ITP, car accident, right? Splenic rupture, spleen is completely ruptured, and surgeon told need emergency splenectomy immediately. There is a massive hemorrhage inside the abdomen. What you do? Patient's platelet count is 5,000. Another scenario, what you do? Give IVIG, life-threatening bleeding, less than 5,000, life-threatening bleeding, right? Immediately or as fast as possible, you IVIG. So how I manage this patient? If same patient I want to manage, I give IVIG number one. Number two, I give steroid. In case of bleeding, I may also use platelet rich concentrate or SDP single donor platelet, right? And then I treat supportive. This is my treatment plan, being hematologist, right? So prednisone takes time. It won't immediately increase. It won't immediately reduce the destructions of the platelet. Antibody or antiplatelet antibody, nobody does in this world. This is just for the academic purpose. And antiplatelet antibody is GP23B. This is the name of the antibody, but nobody does world over. Irrespective of the antibody, whether antibody is present, my treatment will not change. If antibody is absent, my treatment will not change. So considering this, whether it is present or absent, my treatment is not changed. Then why I supposed to do the antiplatelet antibody? And it is not done though so easily. It will waste the time. Patient is already in intracranial hemorrhage. So before antibody comes by evening, he will die. So would you like your patient to die by just waiting the antiplatelet antibody? No. So C is not the answer. Hematology will not add anything because this is known case of ITP. This is known case of ITP. So acute myocardial infarction, another same scenario, right? You give MONA, morphine, oxygen, nitrate, aspirin. This is first line treatment. You don't need cardiologist consultation to give aspirin to the acute MI. So if you have a chest pain, patient comes to the emergency, you see ST elevation, don't call. 100% don't call cardiologist, give aspirin. That's it. What cardiologist will tell? Give aspirin. So why you are wasting the 1 hour of time? And 1 hour of time wasting in acute MI means you are making the patient to die. You are making prognosis bad by waiting. Don't wait. Give MONA, give morphine, oxygen, nitrate, aspirin. Then you call cardiologist, then you call PCI, then you call thrombolytic, then you call whatever you want to do. But first, stabilize the patient. Give something to the patient. Always remember, this is my experience, and this is what all the MTB 2, 3, Master the Board, First Aid, Harrison, Davidson, Oxford. I read all the books many times, 100 times before my lecture in last 20 years. All books say they are all against consultation. First do something and then do the consultation. First do something, then do the consultation. That's it. So consultation is not the good answer. Bone marrow biopsy is not required. Why? Because it is already ITP. Sonography will not add on the anything because the patient has no intra-abdominal bleeding. He has an intracranial bleeding. So now the last two answer is prednisone or IVIG. So IVIG because this is life-threatening bleeding. So any life-threatening bleeding, you must go and give the IVIG. That's it. So whatever the answer, whatever the options they gives, our mind is now clear. Our mind is clear now what to do in ITP. So just read the options, just read the questions carefully and you give the answer. That's it. They may change the option, prednisone on first, last, or now there is no life threatening bleeding. Now they give the non life threatening bleeding. So answer is prednisone. We don't need to confuse. Options are same. They will keep changing the question. Options are same. But now we have a clarity what to do, what not to do, when not to do, when to use IVIG, when to use steroid. That's it. So this is all what from my side. So thank you very much everyone for listening me coolly and calmly. Before I leave the class, I would like to have quick feedback of 2, 3 people, those who joined my class first time. I want to get little feedback. How did they enjoy and how did they learn? That's it. Very quickly.
Best, sir, best. Nothing to say.
This sir. Sorry, your
Best,
name is
best. Likon, sir.
Great, sir. Great, sir.
Likon. Sorry,
That
Really
was
happy,
your
very
sir.
name is not
helpful
seen, so
and
I don't
interesting.
know what. Yes,
Sir, I
Likon.
logged in from hospital, so phone is.
Sorry, sir. I'm not getting your voice. Yes,
Okay.
Shalini, how was your experience, Nasrin? Any feedback?
Yes, the
Your
first of all, I
explanations are
want,
very clear, sir. Yeah, thank you so much for the explanations.
Wonderful. Your
sir, thank you so
Well,
explanation
much.
makes the change. Yes, please.
yes.
Yes,
Good day.
Jamila.
I also joined. This is my first encounter with this group, and I assure you, this is a very beautiful presentation. You are really delivering the message and making us understand what all the everything that we need to know about the management of certain diseases. And then this has gingered me more that I'm tempted to go and read all these things up again. So
Sure.
thank you very much. Thank
You
you.
are welcome, dear. Yeah. I just try to give little idea how you supposed to prepare, not just mugging up the things. You understand? Otherwise, everything
Yes.
is book. I did not did any magic here. Everything is
Yes.
in the book. But the presentation or my experience probably help you more rather than just reading. And it
Yes.
probably open up your mind how to prepare, what to prepare.
Yes, thank you
Yes,
very
Mitu,
much.
yes, you're welcome. Yes,
Mm.
Dr. Mitu, Dr. Shahid, any comment? Okay, fine. Thank you. So if no comment, I will stop it here. And thank you very much, everyone, for your kind attention. We'll see you in the next class. Thank you.
Thank you, sir.
Thank you,
Thank
sir.
you so much, sir.
Looking
Thank
forward
you.
for the next one. Thank you.
Thank you. Take care. Bye bye. I'll keep you updated in the group. Don't worry.
Okay, thank you.
Thank you.